Good evening and welcome to UPMC Sports Surgery Clinic's talk on common rugby injuries, prevention and causes. So I'm Fiona Roach, I'm the Business Development Manager here in the Sports Surgery Clinic. For any of you that don't notice, we're based in Santry in Dublin. We're about 10 minutes from the airport, just off the M50 and the M1. We're a leading orthopaedic private hospital in the country. We have a reputation internationally and nationally for sports medicine and orthopedics. So we do all things musculoskeletal, from hip replacement, knee replacement, spines, your neck, your fingers, toes, shoulder replacements, and also soft tissue injuries such as ACLs. We have an excess of 40 orthopedic consultants here and 9 sports medicine physicians, and all are supported by very specialized physiotherapy, strength and conditioning, and nursing teams. We have 7 theatres here, 3 MRI scanners and a CT, and in excess of 100 beds. Now, so tonight we have 3 speakers. All the speakers are going to have a presentation and they're going to join us live for a Q&A. So you see a tab there for Ask a Question. So please write in your questions there and we will endeavour to answer them all. Now, our first speaker tonight is Dr. Stuart O'Flanagan. Stuart is talking about common injuries in the Rugby Sevens. He looks after the Rugby 7 Irish team and also the Leinster team. So Stuart's going to join us after the presentation and we'll talk then. Thank you.
Good evening. My name is Dr. Stuart O'Flanagan. I'm delighted to speak to you this evening on this rugby-themed webinar series. I'm going to talk to you a little bit about Rugby Sevens this evening and some common injuries. So while it's a very exciting time for the men's 15s as they start their World Cup journey, in a little under 12 months' time, we're going to have, for the very first time, 2 Irish rugby teams in the Sevens competition competing at the Olympic Games in Paris in 2024. So I thought it might be nice to share some insights into the program there. So this evening will be a whistle-stop tour, providing an overview on Sevens rugby. We'll have a look at the Irish National Sevens program. I'll talk about some common injuries, also look at injury prevention and the approach we take here in the clinic. But what I would say is that although it's the same pitch and the same shaped ball, Sevens is a slightly different sport and is much more amenable and has many more similarities to other field sports like Gaelic games here, soccer, and so on. So my background, I work here in the UPMC Sports Surgery Clinic in the Sports Medicine Department as a consultant. I also look after the medical side of the National Sevens program, as well as supporting the men's national team. And I'm also a team doctor with Leinster Rugby. So Sevens rugby is exactly as it says on the tin. It has 7 players on a full-size field. Games are comprised of 2 7-minute halves, and typically a tournament will involve 2 or 3 games over the course of a day in a tournament, which is usually over the course of a weekend. Typically, there are 3 forwards and 4 backs, so a scrum will have 3 people in it, as opposed to 8 in the 15-a-side game. And what that does is provide a lot more space around the pitch for people to gain ground, and certainly rewards the people who are fast and athletic. I'm going to share a clip with you of a well-known Irish Sevens rugby player, Jordan Conroy, just to show you how quick these players can be.
Let's see what Ireland do with it. McNulty is the target in the lineup. Kennedy in midfield. Conroy is with him. Conroy goes on the outside. It's Conroy!
As you can see, he's getting up to 36 kilometers per hour in terms of speed. And some of these players really are sprinters, covering up to 10 meters per second. And while they're very good at running in fast lines, they're also very good at changing direction. As you can see here, sidestepping in and out and weaving through players. So speed, pace, power, quick footwork are all rewarded. in the game of sevens. So the IRFU National Sevens Programme was established a number of years ago and has rapidly evolved. They're now made up of two squads, men's and women's, with about 20 players per squad, the majority of which are professionally contracted. They're based at the IRFU High Performance Centre, which is in the National Sports Campus in Abbottstown. And the facilities really are state of the art. There are 3 outdoor pitches. There is a half-sized indoor pitch for skills and when the weather is less pleasant. They have a fully equipped gym, medical and physiotherapy suites, recovery rooms, hydrotherapy pools, rooms for video analysis, and probably the players' favourite is the canteen with some full-time chefs who provide them with their meals during the week. And these players are based here all through the week, Monday to Friday, and then travel around the world to take part in sevens tournaments. So our 2 squads compete in the World Series, which has recently been rebranded, and there's 8 venues across 5 continents. The men's and women's competitions mirror each other. And so exotic destinations like Dubai, Cape Town, Perth in Australia, North American venues such as Vancouver, LA, Hong Kong, Singapore, and finishing in Spain are the destinations for tournaments this year, which our men and women will be competing in. This is also going to be a very big year for our teams, as mentioned, as both teams have qualified for the Olympic Games in Paris in 2024. And you can see a picture of the Stade de France here, where the World Cup final is going to be in October of this year. And then in July of next year, the Olympic Games with our sevens teams will be competing in this stadium. And our women's team qualified earlier in the year in Toulouse via the World Series, finishing in the top 5 for the first time ever. Shortly followed by our men's team, who qualified in Krakow in Poland through the European Games earlier on in the summer. And this will be our men's second visit to Olympics, having qualified for the last Olympics in Tokyo, which was played in July of 2021. I was very fortunate to have travelled over to that, to a very different games during COVID times. As you can see, the empty stadiums, essentially where the entirety of the Olympic Games was played behind closed doors. So we have probably about 80% of our men's squad who have been to an Olympics, in addition to staff. So lots of experience going into Paris, which will be a huge experience for everyone. So I'm going to touch a little bit on the types of injuries that we see in sevens rugby. And while there are lots of similarities with the 15s game, this game is much faster, quicker, as I said, rewards quick, powerful, evasive players, and it's all about playing for space and avoiding contact. The types of injuries we see can be categorized into a few different areas: contact injuries versus non-contact injuries. Contact injuries occur in tackles or rucks, whereas the non-contact injuries are very much related around running and sprinting in particular, which we'll touch on shortly. We can also look at injuries in terms of training and games. So what are the types of injuries that happen during a training session? And what are the types of injuries that happen in a game? Typically, games are higher intensity with lots more running at high speeds, much higher collisions. And oftentimes the injuries in games can be related to contact situations. And then we often look at injuries in terms of incidence and severity. So how many injuries of a certain type are we experiencing every year? And how severe are they? So we might have lots of muscle injuries that are keeping players out for a week or two, but we might have more severe injuries such as a broken bone or a sprained joint that might take longer. So these are the kinds of things that we look at when we think about injuries in sevens rugby. And in the RFU, we perform an annual injury surveillance. And what that does is it helps us look back at the year just gone, but also allows us to compare the years prior in terms of what kind of injuries we are receiving in our squads. So is there trends that we can look at to try and reduce or prevent future injuries? And are there things that we have addressed that have been issues in the past that we are now getting better at? And in the last 12 months, we've had a good overview of the men and women's squads with some similar type injuries. The most common injury in training for women is ankle sprains, and the average time from injury to return to play is around 3 weeks and 24 days. In games, calf injuries are the biggest or most common type of injury that we see. Typically, players recover within 15 days. When we look at the men's side, hamstring injuries tend to be the most common injury that we've seen, and the average time to return is about 27 days. And in games, it's more contact-related injuries and ankle sprains with an average of 25 days to return. So you can see that on average, a player may be out for 3 or 4 weeks when they sustain an injury in a game, and it tends to be the lower limb, so the joints and muscles of the legs that have been impacted most, and that works back right across the last couple of years. So what are the most common causes of injury? And I alluded to it previously. Sprinting and high-speed running are really the big things, and less players on the pitch with more space means more time for sprinting and trying to run away from people. Oftentimes those sprint efforts will be somewhere between 20 and 80 meters, so they could be running the length of the pitch, and they could be doing it repeatedly over the 7 or 14 minutes in the game that they're playing. And so hamstrings, very common across all sports, particularly field sports, Gaelic games, soccer and rugby, and sevens is no different. A lot of our players have previously been involved in athletics and have done lots of running, and so are very well exposed to sprinting and running. But even still, at the intensities that they're playing at on the World Series, hamstrings still tend to be one of the main issues. Calf is another muscle injury, more common in the female players this season, but again, for the same purpose. And as well, as I showed the videos earlier, Jordan Conroy weaving in and out of players, change of direction is a big thing. And so lots of demand on the ankle as players sharply decelerate, change direction, sidestep, and go again. And certainly that is one of the reasons that we've seen particularly injuries to the ankle this year, as well as the contact situations where players get caught up in tackles, their feet get planted in the ground, they're twisting and turning, trying to get out of tackles where the ankle can roll or turn and be injured. And so treating hamstring injuries is something that we're very familiar with, and it's really important to have a good idea of the anatomy and how the muscles work, and in turn, what the demands of the players are, so that we can help treat the acute injury. As you can see here on the MRI scan on the right-hand side is what we use to make diagnosis of hamstring injuries. This allows us to grade it between a 1, 2, and a 3, and to help us figure out the timelines as to when a player will be able to return. This gives us an indication of how hard or how quickly we can push an injury, and also when they're going to be next available. Similarly, with the calf, a very important group of muscles made up of the 2 gastrocnemius muscles on the outside and the deeper soleus muscle, all 3 equally important as they combine and run into the Achilles tendon. And again, we use modalities such as MRI to assess for injury to help us better understand what the type of injury is, but also what the timelines will be for return to play for these athletes. A big area of focus for us is on ankle stability. And as you can see on the left-hand side of your screen, there are lots of ligaments stabilizing the ankle, both on the inside and the outside of the ankle, as well as the top of the ankle. And one type of injury we've seen more commonly in the last number of years is a high ankle sprain, also known as a syndesmosis, which is a ligamentous structure keeping the joint stable at the top of the ankle, both at the front and the back. And this is something that we've seen probably more related to the surfaces that our players are playing on around the world in terms of harder pitches in warmer climates, as well as some of the stadiums, particularly in North America, where they can be baseball or NFL stadiums where they are artificial grass stadiums where the grounds are harder and there's more impact going through the ankles. So in the sevens program, we put a lot of focus on prevention. And my area of interest is much more on preventing injuries rather than dealing with them initially. So if we can prevent them coming, knowing what we know from the last 12 months, but perhaps maybe the last 36 months, we can try and address that in the weekly schedule. So as you can see, here is an example of a week for a player. And this is all of the work they do outside of rugby. So this is off the pitch. So we often do quite a lot of work in the gym in preparation for pitch sessions. So focus will be on movement health. So getting the hips, spine and hamstrings warm and loose, as well as getting the muscles around them active. We put a lot of focus on the shoulder. As you can imagine, lots of rugby tackling needs good shoulder health, as well as putting some work into ankle balance, control and strength of the muscles surrounding that. We put big emphasis on what we call posterior chain or hamstring and gluteal strength, as well as neck strength, which is something we use to help prevent concussions. And this might be done on several days through the week, as you can see on the schedule. And this is all in preparation for training and playing, but also preventing injuries based on what we've seen before. And of course, we have the team approach, but we also have the individual approach. So some exercises will be very specific to a player and their injury history in particular. So you can see an awful lot of work and thought goes into preparing a player in the week, and this is an average week outside of tournament times. So the kinds of things we look at are for the hamstring, strength and high-speed running. So high-speed running is the equivalent of a vaccine for our players in terms of hamstring injuries. So we look to ensure they get a number of exposures during their training week where they're running at very high speeds. We constantly work on the strength of the hamstring and the muscles surrounding that. And similarly in the calf, the three muscles I mentioned, we look at training them regularly with heel raises with a bent knee and a straight leg, for example, as well as sprinting and endurance running. Lots of running volume is important for the calf, and our players cover long distances repeatedly. So it's ensuring that they have enough in the tank to be able to do it, particularly when the intensity is very high in warm temperatures, often very humid conditions also. And as I mentioned, strength, we look at, of the ankle, we look at stiffness. So you can see some jump testing in the bottom picture there, where we are getting real stiffness into the ankle to allow players to withstand the forces as they run, jump and evade the opposition. And our approach here in the clinic is very similar. So we look at any athlete that comes in. And as I said, a lot of the injuries that we see in sevens, I see on a daily basis, particularly now at the moment in championship time in Gaelic football and hurling, but also soccer, hockey, and we get a lot of athletics athletes in at the moment as well. Many of them have transitioned to sevens over the years. So we look at the history, what's the injury been, how many have there been, and of course, focused examination. We often utilize imaging, as I mentioned, such as MRIs, to make the diagnosis, to allow us to understand what structures have been injured, and also to give us an idea of the timeline. And there's various structures in the hamstring, including muscle, fascia overlying the muscle, and tendon, which runs through it. And each of those has a different way of managing and helping a player return to play, often with strength and then running and high-speed running in time before reintegrating into playing and training. We look at other measures such as strength. We do a lot of isokinetic dynamometry testing here. You can see some strength testing of the thighs in that picture. And we also look at jump testing as well as a measure of reactive strength. And ultimately, that culminates in a rehab plan for the athlete to help them return to whatever sport they like to play. In the aim here really is, as I mentioned, prevention, trying to get them back once and for all, and to reduce any risk of future injury as a result. So that concludes my talk this evening. I hope you've found it enjoyable. very many thanks for your time, and I hope you enjoy the next few weeks, and hopefully we see Ireland doing something special. Thank you.
Thanks, Stuart. Really interesting talk. I learned a lot as well about the Rugby Sevens. So first question, what is the best way to manage a player that keeps having an ankle strain?
Yeah, thanks, Fiona. Well, ankle sprains are really common, and it's probably the most common presentation of a joint injury that appears in an A&E clinic and physio clinics around the country. And the biggest predictor of a future ankle sprain is a previous ankle sprain. So prevention is really key. And once you've managed the early stage of the sprain, the swelling, the pain, and making sure that there's nothing more serious, physiotherapy is really important, and making sure that you restore the balance, what we call the proprioception, and improving the strength of the muscles around the ankle, which can drop off really quickly, particularly the calf, and the muscles around the gastrocnemius and soleus, which I mentioned in the talk, are really critical for that. And once you've got a good level of strength, you can start returning to hopping and jumping, and once that's all good, you return to running and move back into sport-specific drills. So the big thing really, from my perspective, is prevention, because they do happen, and it's the most common injury, and it's really about managing that well so that you're robust enough to return to play sport, or any direction changing activities.
Yeah. Okay, there's actually a question just came in similar to that from Robin Brown. Said, what to do if you had a grade 3 tear in the 3 ligaments in your ankle and keep spraining it? So you've probably kind of answered part of that there for him.
Yeah, and the big thing there with that type of an injury, it's obviously a high grade injury, and you've damaged all the ligaments. I'm guessing on the outside of the ankle, the lateral ligaments, and so it's really about the clinical assessment is important. So when you have that level of injuries, you have potentially a ankle instability, and as I mentioned, the thing that we want to prevent is recurrent sprains, because you can get damage to the joint, the lining of the cartilage, and things like that. So it's really about trying to improve the balance, the proprioception, and the strength, and making sure that the athlete feels stable and not vulnerable. But if all else fails, then you're looking at getting some help from our foot and ankle orthopedic colleagues. And on occasion, rehab doesn't work out, or the joint is not stable, and we look at procedures then to stabilize the joint with surgery. But we try as best we can to see how well we can manage. And you'd be surprised, and I've had capped rugby players, All-Ireland hurlers with really high-grade injuries who actually do very well. But when you involve all 3 ligaments, or even the ligament higher up with the syndesmosis, that's more of a challenge, and it very much kind of depends on the clinical picture and the assessment and function and reassessing at short intervals.
Great, that's great. So Dara says, what is the difference for training between a 7s player and a 15s player?
So quite a bit. So even though the ball is the same shape, the sport is they're quite different. So the same pitch and less players on the field, so more space, and so more running, and so more high-speed running really. So the players tend to be lighter and quicker. There are some bigger, heavier players, but generally they're more like sprinters and track and field athletes, or similar profiles to GAA athletes as well sometimes. I remember a couple of years ago we had some players who came across from one of the 15-a-side provincial teams, and they did more high-speed running in a warm-up for a training session than they'd done in the whole season, and that was measured on the GPS, the little units they wear on their back. So there's lots more running, and there's lots more adaptation that's required to protect people from the likes of hamstring injuries and calf injuries because of that.
Okay, thank you. Question here from Joe. He said, what's the best way to build and stretch your hamstrings to prevent pulling them?
Well, hamstring strains and injuries are another big thing that we see a lot of in the clinic here. And by the time they end up in my clinic, often they've maybe had 5 or 6, and often tried to make their own return, maybe tried some physio and some rehab, or sometimes they just take rest. And the big thing is getting the diagnosis right from the start. Here we use MRI quite often, because it tells us what type of injury it is, whether it's a muscle injury or whether it involves a tendon which runs through the muscle. And that gives you an idea of the timeline. And sometimes people injure because they come back too soon. And sometimes there's no way of knowing without a clinical assessment, but probably something like an MRI as well. and it just helps with that. So generally, to answer the question, the stronger the hamstring is and the muscles that support around the hip and pelvis, the more robust people are. But also, sprinting is like a vaccination in addition. So if you're playing a sport where there's lots of running or high-speed running, you have to be strong, but you have to be used to running and be used to be running fast. So they're all the things that we look to do to try and prevent injuries. We worry a little bit less about flexibility. It's really important. But if your muscles are ready for running and changing direction, we can work around hip mobility and movement around the back and things. But that's the principle we take: strength, sprinting, and then making sure we have the right diagnosis from the start.
Okay, thank you. It's just a comment here from Sean Keane. She said she has not a question, but she just wanted to say thanks. This is very informative, great information. Thanks. Stuart, thanks for joining us tonight. So our next speaker tonight is Dr. Jamie Kearns, and Jamie's going to talk about concussion updates from the Amsterdam conferences. Jamie is the Munster doctor also, and he has looked after the Connacht team and the senior male team in the past as well, been on their medical teams. So we're going to show his presentation, and then Jamie's going to join us afterwards for a live Q&A. Thank you.
Good evening, everyone. Many thanks for the invitation to present today. I've been asked to give an update on concussion, particularly post the recent Amsterdam Consensus meeting in October of last year. This was a group of world-renowned experts and both clinicians and researchers who came together to discuss the research that has been done in concussion over the last 4 to 5 years and try to collate the most up-to-date research in regards to both concussion identification, management, and long-term outcomes. So this meeting, as I say, took place in Amsterdam last year, and the publication of that research was in July of this year in the British Journal of Sports and Exercise Medicine. So I'd like to take the next 15-20 minutes to maybe present some of this latest uptake and research and its relevance to the community game and to people playing rugby at the non-elite level. So, as mentioned, this was the 6th International Conference of Concussion that took place in Amsterdam last year, and the publication then was in the British Journal of Sports and Exercise Medicine over 2 publications in July of this year. So with regards to concussion, I suppose the first thing that they wanted to undertake was what is the definition of a concussion. And how they define it specifically in relation to sports is it's a mild traumatic brain injury caused by a direct blow to either the head, neck, or body. And I think firstly, it's important to be aware that the definition doesn't suggest that it has to be exactly a head impact, that a force that can be transmitted to the head from a knock to the body or neck can also cause a concussive episode. It's important that with regards to that you're not waiting for it to be specifically a head impact, and that also important is that symptoms may be delayed in onset. While the majority of symptoms may present immediately, they may also evolve over the coming days, particularly up to 72 hours after a head injury episode. So just to be aware that not all players or individuals will present with symptoms directly after the episode. Of note, no abnormality is seen on standard scans or imaging. So things like CT brains or MRI brains would be normal after concussion. And really these tools or devices are used to outrule any more serious pathology, particularly things like a brain bleed or something where there's more serious concern. But unfortunately, the current technology won't be able to diagnose a concussion from a scan or an imaging test that you have done. The range of symptoms do not always involve loss of consciousness, and I think that's important to be aware. There can be less than 25% of concussions will actually have a loss of consciousness. So not to be waiting for a loss of consciousness for this to be a diagnosed concussion, that you don't need to be knocked out for this essentially to be a concussion. I think that's a really important message to be aware of. And I think the knowledge around that has evolved over time and people are much more aware of this. What happens is that there's a cascade of events in terms of internally that we can't specifically measure, where the neurotransmitters and brain energy systems are affected, and that's why the signs and symptoms can evolve over time and lead to different presentation of symptoms at different time points. In the context of Irish rugby, and making this relevant to us in our presentation, the IRIS study, which has been undertaken in the University of Limerick since 2016, would look at the rates of injury across both amateur rugby in the AIL and schools rugby within schools senior cup. And within that, it's been noted that over every season, really, concussion has been noted to be the highest injury in terms of prevalence and incidence. And that likewise within schools rugby, again, concussion would account for approximately 14% of all injuries. Within the AIL game, it's somewhere between 11 and 14%, and slightly higher in the women's game, between 10 to 19%, depending on the season. So certainly this is a common injury and something that we need to be aware of and well clued in terms of how to manage it and be up to date in terms of the research. The average length of time off from a concussion within the amateur game is approximately 27 days for men and about 51 days for women. So certainly within the amateur game, there seems to be a delayed return to play within the female game, and whether that's down to lack of access to maybe medical care or prolonged symptoms, that is something that needs to be investigated further. But overall, the research would suggest that there is no difference in terms of return to play between males and females in sport in other settings. So this may well be a reflection on the level of medical care that maybe people are getting in the female game, and that maybe a delay in diagnosis potentially is causing this. In schoolboys, the average duration off was about 30 days. Again, some of that's going to be mandated by the RFU with regards to their mandatory stand down of 23 days for under 18s and 21 days for the over 18s or amateur game. So the key bit in terms of education and how to manage concussion really is around the recognition. And with regards to that, one of the newest tools that was developed within the consensus meetings was the Concussion Recognition Tool 6. So this is a specific tool used for non-medical personnel. So those who are attending a game as a coach or parent, or even as a non-medically trained assistant at a game. So within this, there's a framework of things that are important to look at. So one of the most important things as a starting point is the red flags, or things that we look for that would suggest something more serious than a concussive episode, or would warrant further immediate medical attention. So within that, you'll see the middle section there has a red flag section of things that would warrant the contact of the emergency services. The next page and the following page then has a breakdown of things that would help us to identify a concussion once the red flags have been ruled out. So within that, they would look at things where maybe some visible clues, or things that the injured individual might display in terms of a loss of consciousness, maybe some balance problems, or things like maybe a brief seizure or unsteadiness. After that, then it's a question of what the person themselves or the individual may present with, or the symptoms that they report. So in this situation, they might describe some physical symptoms, some maybe emotional symptoms, or even changes in their cognition or thinking. So sometimes people may present with immediate symptoms of just confusion, or feeling like they're just a bit disorientated, or potentially that they just aren't quite aware of their surroundings. Anyone presenting with immediate symptoms, particularly of headache or dizziness on the pitch, should be removed straight away, as these are people who will tend to have prolonged symptoms if it's not recognized. Finally, they give an advice section around advice to give to someone with a suspected concussion if they're not being transferred to the emergency department for further onward referral. So these should be medically assessed before any return to play. They shouldn't be left alone, particularly in the first 3 hours, as this is a time period where worsening of symptoms might warrant medical attention. They shouldn't be on their own, and again, should not use alcohol or recreational drugs that would potentially confuse the situation and may lead to altered cognition and presentation, which would then confuse the presentation of the individual if they were to have further, more serious underlying medical conditions. Again, they shouldn't drive a motor vehicle until cleared to do so, as there's a concern about a post-injury seizure, and that would cause, obviously, a serious road traffic accident if someone's to drive in that situation. So the number one thing that can be done for a certain person in this situation is to remove them from play. And the saying should really be, and this is the common across all games, is that if you're in doubt, you should sit them out. The reason for this, obviously, is to prevent any further episodes. So people who continue to play with symptoms of concussion will develop a much more severe concussion if they're to get a second episode, which will lead to much more prolonged symptoms. So certainly this would, by removing them from a second injury, you would reduce the severity of concussive episode and shorten the duration of any symptoms post that injury. The other serious thing to look out for is a thing called second impact syndrome. And this is where if someone received a second head injury or a second concussive episode, that there can be a very rarely episode of significant brain swelling, which can be very serious and lead to seizures, and also in some cases can be fatal. So this is obviously a very important thing to recognize and prevent from happening. With regards to those who've been diagnosed with a suspected concussion, particularly within maybe an amateur setting where there hasn't been medical input, it is definitely been shown that the earlier someone receives medical attention after a concussive episode, it shortens the duration of that episode. So within the medical setting, whether it be that with their primary care physician or a sports physician or someone who specializes within concussion, that the players should be reevaluated. And usually once it's past 72 hours, they have devised a device called the SCOTE-6, which is the Sports Concussion Office Assessment Tool. There's also a child-based version of this for those who are 12 and under. This is a multimodal assessment which involves both a symptom checklist, neurocognitive testing, some balance assessment of vestibular function, autonomic nervous system assessment, and then also a neurological and cervical assessment to outrule any more serious pathologies that need to be treated prior to managing the concussive episode. It does incorporate screening for underlying issues such as anxiety and depression, and these are not mandatory but may be optionally used if the person was to present with prolonged symptoms that maybe are being complicated by the development of maybe some anxiety symptoms or depressive symptoms that can commonly occur after a concussion, but also if present prior to concussion can lead to more prolonged symptoms. As I say, this is best used within 72 hours to up to 30 days post-injury and can be used within the setting of a primary care setting, and takes a bit of time to do, but gives a very good direction towards where, if treatment needs to be directed in terms of rehabilitation, this can help guide that. With regards to the rehabilitation of concussive episodes, I think it's important to be aware that most episodes are self-limiting and that will resolve spontaneously on their own. It is important to be aware, though, that 30% of people will experience post-concussive symptoms or what are now called persisting symptoms. And that's a slightly higher rate in those under the age of 18, as they'll tend to take a little bit longer to resolve from symptoms. Prolonged rest is no longer recommended. And I think this is an important message to get across in terms of the return to activity after a concussive episode. And it's been shown that those that are prescribed prolonged rest actually take longer to recover, and that a self-limited and self-directed return to normal activities of daily living within the first 24 to 48 hours is actually important. So allowing people to do normal low-level activity in terms of walking, activities of daily living, but maybe reducing screen time for the first 48 hours has been shown to reduce the persistence of symptoms. After that 48-hour period, I think it's important then to encourage return to exercise in a very graduated and personalized way. Within that, it's worthwhile aiming for a low level of activity with up to about, if it's not prescribed, 50% of what would be considered the maximal heart rate that produces symptoms. So if that's something that you're not able to have prescribed by a physician or a physiotherapist, then aiming for about 50% of your maximal heart rate in terms of a bike, and a low level 15 to 20 minute activity on a bike is usually quite a helpful thing from the starting point. This will then be progressed on as symptoms are tolerated, and can progress on to a maybe running based activity over the following 24 to 48 hours. We're happy that as long as there's only a very mild exacerbation of symptoms, that this is okay to progress on. And within a mild exacerbation, that would really be graded as something where it's approximately a 1 to 2 out of 10 in severity. So as long as the symptoms aren't increasing by more than 1 or 2 out of 10 and are resolving quite quickly, then we're happy for people to progress on in their rehabilitation to allow them to return to activity, as this has been shown to be the best treatment in terms of reducing the prolonged nature of symptoms after a concussive episode. So within that return and rehabilitation, this is a simple guide that would guide the staged and graduated progressions. Within it, you can see that those first few days of step 1 is a symptom-limited activity that don't exacerbate symptoms, and then generally progressing on to that light exercise of up to 50 to 50% of a max heart rate. That can be simply calculated by a simple formula is 220 minus age. Within that, that might be a stationary bike, and that's usually quite beneficial as it prevents any head movement, and then progressing on to say maybe moderate activity or increasing heart rate running based activity. The first light blue section is safe to progress on without the need for medical clearance. And this is really designed to allow people to return to activity, which is both helpful, but also is good in terms of their progression back to reincorporation into both training and their sport. The second darker blue section should be used as after someone's been cleared to return to maybe a training-based activity. The upper section would be one where there's a low risk of any further injury and there's no risk of any head impact at that stage. Whereas once you start to progress into that lower section, that is when the risk of maybe a further or subsequent head injury starts to increase. And that's why we'd like to delay that bit until medical clearance. Important for both students and even those returning to work is this return to learn process. Again, this is individualized, and the majority of people will have returned to full learning at approximately 10 days. However, it is important to be aware that up to 40% of individuals may have some academic dysfunction or disability when it comes back to learning, in terms of struggling in the schoolroom, struggling in the classroom in the first couple of days after a concussive episode. And that by not recognizing that, it can lead to prolonged symptoms again. Again, these are the people who really would struggle in this situation, those with the greater initial symptom burden. So those who present with maybe very severe symptoms on day 2 to 3 after a concussive episode, they'd be the ones who maybe would be more likely to benefit from a personalized approach to their return to learn, where maybe some modifications around the length of time the person goes back to school, or maybe reducing the amount of homework in the first 24 to 48 hours will help with the return to activity and return to normal learning. With regards to the return to sport, the average time to being symptom-free is approximately 14 days, and return to sport is approximately 19 days for most athletes. Again, this doesn't tend to vary between males and females, but there is a slightly longer duration for those under 18, up to 16 days, and then 19 days versus 9 days and 15 days for those over 18. Factors that would increase that time tend to be that delayed removal from a game. So someone who suffers an injury within a game and then plays on with persistent symptoms. As mentioned earlier, delayed access to a healthcare professional can also be associated with a delay in return to play. And also initial higher symptom burden and severity of symptoms at the time of presentation has consistently been shown to predict how long someone will take to return to play. With regards to onward referral, those who are struggling with persistent symptoms, those with recurrent episodes of concussion, those complicated but maybe symptoms suggestive of a mood disorder with anxiety symptoms or low mood, maybe issues around sleep or reluctance to engage in activity, and those with parental concern or the athlete themselves is concerned should really be referred on to a specialist who looks after individuals with concussive episodes and would understand the management going forward. One of the new areas that they've looked at within the consensus statement is the ability to reduce the level of concussive episodes. So there is increasing evidence for the use of mouth guards, and this would have come from ice hockey within Canada. But certainly some of the previous studies in rugby would suggest that maybe while non-statistically significant, that the use of mouth guards has shown to be beneficial in reducing the number of concussive episodes. Other ways we can look at that is in terms of policy change, and obviously the IRFU have brought in the reduction in tackle height, which has been shown both in France and abroad that has reduced the overall incidence of concussion. The reduction of contact within practice sessions has been shown to reduce the episode of concussion within NFL and has been taken across throughout rugby, where the level of contact is reduced throughout the training week to prevent the number of concussive episodes in training. And that is evident within the statistics in both the Irish study, which shows that the number of concussive episodes within training is actually very low. The majority of concussive episodes seem to happen within the match setting. Another thing that has been shown to reduce potential concussive episodes is neuromuscular training warm-up, which was shown in England to reduce the episodes of concussive episodes and all injuries. And this is something that can be coordinated through the strength and conditioning coaches prior to a training session. And then important is the early identification of a concussive episode to reduce any recurrent episodes, as early identification and management reduces the severity of the subsequent episode and how long that person will take to return to play. So again, early identification, recognizing and removing that individual is probably key to preventing further episodes. Finally, a question we get asked is, when should someone consider not playing a contact sport anymore? And this isn't specific to rugby, but can be across all sports. But I think those that, while there's no specific set guidelines and no specific evidence to guide this, in terms of factors, we would look at people who maybe have prolonged symptoms or persisting symptoms after a concussive episode. Obviously, if there's any neurological abnormalities on a physical examination, those people should not be cleared to return to rugby until that's fully assessed. Any deficits on neuropsychological testing despite time away from contact sport, again, would suggest a need for reassessment. And it should really be a multidisciplinary approach where the person is seen by a number of specialists who work in concussive management, who would be able to guide the decision around returning to contact sport or avoiding contact sport. One of the things we look at is concussions that are maybe evident after a lower impact. So maybe a transmitted force causing concussion that previously wouldn't have, or obviously anything that has any structural abnormalities, again, would be warranted further neurosurgical or neurological review. And these are all things that need to be taken into consideration. This should obviously, of course, be balanced by the benefit of prolonged participation in activity and physical activity, which are both shown to reduce the incidence of future both mood and neurological disorders, as well as the benefit of team-based sport for reducing the episodes of anxiety, depression, and isolation that can occur when these are removed. So just in conclusion, it's important again to re-emphasize that early recognition reduces the severity of concussive episodes, avoiding strict rest, as this will only prolong symptoms, and actually the earlier someone can return to activity, the shorter the duration of their symptoms will be, regardless if they've returned to play. That using exercise in a prescribed way and progressive manner is also beneficial as treatment for a concussion, and that early referral is warranted and will reduce ongoing symptoms if the person is not responding to the usual care. So I'd like to thank you for your time today, and we'll look forward to welcoming any questions that you may have.
Jamie, thanks for a really interesting talk. So we have a few questions coming in now. So it's one from Sinead. She's got two questions. She said a teenage son's got bad concussion when playing rugby and has developed POTS due to this injury. Is this common? So we'll ask that bit first.
So POTS, I assume she means postural orthostatic tachycardia, which is a kind of a sympathetic overdrive that happens after head injuries. Now, it can happen for lots of different conditions, but in essence, this is kind of a disturbance of the autonomic nervous system. And this is a recognized occurrence in concussive episodes. It probably was under-recognized, but is now on the kind of standard concussion assessment tool, particularly the office-based tool. So this is a recognized kind of complication that can occur, but if it's been managed well and symptoms have resolved, then that's a really positive outcome. And because a lot of the time these things get under-recognized. So certainly that's a positive outcome that it's been recognized and managed well, and that he sounds like he's been able to get back to play.
Yeah, she says he's back playing, completing the head injury physio via neurology and under the care of cardiology. Should she be concerned about a secondary concussion?
Yeah, I suppose generally it depends again where you talk to people, but I suppose the biggest risk of a complicated concussion is having had a previous concussion. Yeah. But generally what you find is that the biggest risk or things I ask people to look out for is either a concussion that's taking a long time to resolve, or one that's happening with less and less impact. So if someone's having a recurrent concussion and it's actually from, say, a blow to the body, or they're holding a tackle bag and they get a concussion, versus the really kind of significant trauma. There is some groups who will say that once you've been rehabilitated fully and symptoms have settled from a concussion, you've been rehabilitated, everything's cleared, that there's no increased risk of concussion. But again, it's possibly debatable. I think that there's always some element of risk, but you have to balance that out versus the desire to continue playing a sport, the social inclusion, the benefit from a physical point of view, all of those things that are kind of positive effects of playing sport. So I suppose it's a balance. Like anything, there is always some elements of risk, but it's just balancing out what the benefit is, and then kind of making an informed decision that way.
Okay, thank you. Damien says, if I have concussion, what are the next steps?
So I think this is probably where the new concussion guidelines probably give a lot more direction, and give people a little bit more control about what they can and can't do, or should and shouldn't do. And probably the key bit is the early introduction of exercise after 24, 48 hours below a level that brings on your symptoms. So actually getting out, firstly, not staying in a dark room for 24, 48 hours, which seemed to be the previous advice. So obviously reduce screen time in the first day or two to reduce the kind of symptoms and severity of symptoms. But after that, kind of resuming activity is tolerated, getting out, meeting people, simple exercise in the form of going walking, and then kind of a symptom limited return to activity in terms of maybe on a bike or something like that, and actually just building up the level, and going through those steps as in the talk, that kind of return to play criteria. What's also been shown to reduce the risk of kind of a worse concussion or prolonged symptoms is an early interaction with a qualified medical professional. Those people who've seen a clinician early do better. They don't tend to have as prolonged symptoms and get kind of guided towards the right rehabilitation for those people that need it early. So I think that's probably a key factor within it.
Okay, thank you. A question here from a team doctor. He said he's a team doctor for an amateur club. Where can he access specialist care for ongoing for players?
So for us at the minute, so the UPMC obviously have a concussion network that's established around Ireland at the minute. So that there's available clinicians probably in lots of the country now, covering a significant part of the country, from Dublin across to the south, to the southwest, midwest, and north as well. So there's certainly good access if you go onto the UPMC website and look at the concussion network. There's availability of clinicians there who have access to both neurocognitive testing from a neuropsychological testing, online impact testing, and then also specialist kind of physiotherapy and vestibular rehab. So there's a good network there if people want to look on that as a kind of a guideline for maybe players that need assistance with complicated concussion.
Yeah. Okay. And actually you can see a tab there it's about UPMC. So we'll have the other clinics around the country on that one as well. So now the question now, it's nothing to do with concussion, but you're happy to answer it, Jamie. It's about how do you diagnose the severity of an ankle sprain after initial symptoms have subsided?
So again, it without seeing the person or knowing the situation, I think the ability to weight bear after 3-4 days and get the swelling down is usually the key bit we look at. Once a player in our care, if you imagine in the rugby club I work for, we'll look at maybe some loaded exercises in terms of their ability to do a calf raise, do a weighted calf raise. And then we have a kind of a guide in terms of our return to run, which will involve kind of a number of hopping type exercises and things like that before maybe introducing some straight line running and then change of direction. Once that's clear and the person's clearing all through that, then we'd be happy enough to reintroduce to training. I think the important bit with kind of the common ankle sprain is that a lot of people will suffer from ongoing symptoms or recurrent ankle sprains, and they're the ones that can cause problems long term. So I think whatever about the initial injury, it's the recurrent injuries are the ones we have to watch out for, because they can cause damage to the ankle joint if they're not managed properly. So they'd be the ones where if you're getting someone who's getting recurrent ankle sprains, again, it'd be worth linking with the physio or a sports medicine doctor just to kind of get a proper assessment in that situation.
I think in this case, it's a teenage son that, he couldn't walk, but 10 days later wants to go back into training and has no symptoms. And they were just wondering, was there a standard protocol to ensure he's not returning too soon?
I think that thing of being able to, first of all, walk, weight bear, pain-free, hop, both forward, laterally, those things want those clear. And then introducing some straight line running, then some change of direction. If they're all clear, then I think there's no issue. I think, again, once people have suffered an ankle sprain, we'd normally strap their ankles actually for a period of time afterwards, because the risk of recurrent injury.
Okay. Jamie, thanks very much for joining us. And these talks will be live on our website if anybody does want to go back in or redirect someone to them later. So our next speaker tonight is Dr. Matt Cosgrave, and Matt's talking about common injuries in women's rugby. Matt is the team doctor for the women's Irish team. So Matt will have his presentation. He's going to join us live for a Q&A. Thank you.
Hello, everybody. I hope you're enjoying your evening so far. My name is Matt Cosgrave. I'm one of the sports medicine physicians at SSC Sports Medicine. And this evening I'm here to talk to you about injury in women's sport. I suppose the question is, what makes me or puts me in the position to talk about this? And I've been the team doctor for the national women's rugby team now for the last 4 years. It's been a great opportunity to work with a fabulous group of women. Really interesting time for women's sport and for rugby in Ireland, as the group has just professionalised in October 2022. So there's a lot of change happening. The men's game professionalized almost 30 years ago, and the women's game is really it's coming on at a speed of knots as they try and keep up with the success of the men's game, but trying to do this evolution in a very in a much shorter time period. But if we think about what women's sport is, this is a clip from the World Cup just passed, Soccer World Cup, and this is Federation Square in Melbourne as the Australians celebrate a goal in the semi-final. And really, I just show you that to give you an idea of what women's sport now means to people around the world. It really is, it's a sense of national pride, and it's as much it's of as much importance as the men's sport and the men's national success for many. If we look at the World Cup, some really interesting stats that have come out of it. 570 million, gross, which is the first time that the Women's World Cup has actually turned a profit. In the last 10 years, you'll see that the attendance numbers have doubled, and they're increasing really over the last 20 years significantly and steadily. If we have a bit more closer to home, then if we look at the opening game between Australia and Ireland, at the stadium itself, there was nearly 76,000 people in attendance. And the viewing figures for this in Ireland alone, there was something like 800,000 people watched between RTE and between the RTE player. And that took up something like 80% of viewership on the day. The World Cup final itself in the UK was watched by 15 million people. And to give you a bit of context around that, the men's final a couple of years ago was watched by 19. So it's very, very close in comparison. If we look at rugby, which is really where I'm coming from, then the England-France final day of the Six Nations in 2023 at Twickenham, there was a sellout crowd of over 58,000. And again, if we try to put that into context, the England-Ireland game in the Aviva Stadium had 51,700. So, you know, you're filling out stadiums here. And I suppose from my point of view and from people working in women's rugby, there is a hope and an expectation that at some stage there will be a sellout crowd for a women's game in the Aviva. Then if we look at the All-Ireland final between Dublin and Kerry, we have an attendance of 46,000, and this game regularly has attendance figures in excess of 40,000. And only a few years ago, it was the second highest attended sports event for women, second only to I think it was the 2019 World Cup final at 56,000 plus. So we're seeing this growth in viewing and attendance and interest in women's sport. But then if we start to think about it from a sports medicine and a sport and exercise science point of view, we're really far behind. In terms of female sport and specifically female sports research, this only takes up about 6% of the total research that's out there. There's about an additional 30% that looks at women and men together or doesn't differentiate. And then the remainder of study and research that helps really to direct where we go from both a performance and an injury point of view, it's on men and only men. Today, I'm going to talk to you about a few specific injuries or injuries specific to women's sport or that get a lot of the limelight. And ACLs being one of them, but I'll use the three injuries that I talk about to speak to you about the broader context of injury in women's sport. ACL is a huge one, and from a women versus men, there's definitely an increased incidence of ACL injuries in women's sport. If you look at the literature, it's anywhere from 2 to 8 times an increase in that in comparison to the men, and I suppose that's across different sports as well. So that's why there's so much variation and so much breadth in that. There are lots of reasons behind this, and it really brings us back to a nature versus nurture, or a non-modifiable versus modifiable risk factors. And from an anatomical point of view, the women, a female pelvis is generally wider than the male, and as a result, you get the slight increase of the femur as it goes from the hip down to the knee, and you get an increase in something which we refer to in sports medicine as the Q angle. And this Q angle has been strongly associated with an increased risk for ACL. Similarly, in the knee itself, you have something called a femoral notch, which is this little groove just above where the ACL sits. And it's well recognized that a smaller femoral notch increases your risk of ACL injury. And proportionally, women have a smaller femoral notch than their male counterparts. And then if we look at the feet, a female foot is shaped generally differently to a male. They have a smaller heel cup and a slightly wider forefoot proportionally. And while this may not directly have any effect on the ACL injury itself, it definitely has. It definitely comes into play when we think about things like footwear, and there is much less out there on the market for female sports people in terms of customized footwear. And for that reason, many women wear boots that are either too small for them or are ill-fitting, and as a result, change their biomechanics and how they move, and in turn increase their injury risk. From a menstrual cycle point of view, I thought this is a really interesting graphic that just gives you a snapshot of the changes that goes through the hormonal profile in women throughout a month. And there is definitely some evidence out there that that the change in those hormone profiles can increase injury risk at different times. Right in the middle here is this ovulation period. And in ovulation in the mid-cycle, there's a spike in estrogen and also a slight increase in hormone relaxin, and both of these are associated with an increase in laxity in tissue. And so this increase in laxity in tissue is believed to increase your risk for ACL injury, and the research does show some trend towards that. It's not conclusive, however, and there are parts of the cycle, for example, in the week just prior and just post menses, where there has also been shown some increase in ACL injury risk. So it's not quite clear, but there is definitely something going on there and something that needs more research. The beauty of, I suppose, this change in cycle pattern, and if we encourage women to track their cycle and track their performance, I suppose, throughout the month, is that you can also then use this from a performance point of view, because there is also some evidence to suggest that in that first 2-week stage of the menstrual cycle, women actually have an increased ability to improve muscle mass and muscle strength. So that could be a stage of the cycle that really concentrate on strength training, and I suppose you're maximizing the benefits of the cycle as opposed to just avoiding the at-risk periods. Then if we think about what we can actually change, one thing for sure is that in general, women are not as strong as their male counterparts. And if we think about specifically around the ACL, there is something what we call the quad hamstring ratio. And traditionally, female athletes would have a bigger difference in the quad hamstring ratio than males would. Very strong quads, but relatively speaking, a weaker hamstring complex. And so if we can concentrate on getting this ratio closer together, then that's certainly something that can improve things. In terms of the warm-up and how we prepare for sport, a neuromuscular warm-up across football has been shown to reduce the risk of ACL injury by 50%. And this is not just in women's sport, this is in men's sport as well, but it is definitely something that we can adopt and encourage at all levels, from grassroots right up to professional, that should help to reduce that risk, not just of ACL, but of all injuries. And then if we think about things like technique, traditionally women start the higher level sports participation much later. With men, we tend to find that from a very young age, there's lots of development programs, lots of opportunities, and they get coached right through from early primary school years in technique, in running, change direction, jumping, and for rugby, tackling. In the women's game, this happens much later on, and as a result, all of these things together place women at a slightly higher risk of injury when they're playing at that elite level, or when they're trying to reach that elite level, having had a relatively short time period to build up those skills and to build up that aptitude. And so I suppose what this all boils down to is what we can deliver from a very young age. And it's not just about things like physical strength, warm-up, practice, technique. It's also about what the provision is. We often find that women are playing on, and girls are playing on, pitches after their male counterparts. They're playing in facilities that are not as well looked after and as well prepared. And then they don't have the same degree of resources and education. And as I said, development programs that the boys and the men's do. So it's really about delivering these opportunities at a very young age. All of these things come together and they improve performance, but they also reduce injury risk across the board, not just for ACLs, other soft tissues, bones, and then some of these other things that we're going to talk about going through. So concussion is a big thing in rugby, and I've heard it cited on a few occasions that in women's sport or in women's rugby, concussion risk is much higher. And really, that's not the case. This graphic looks at injury risk across the last 3 World Cup cycles. And if we look at it on the face of it, 3 World Cups ago, the men's injury risk in general, that top blue line, was more than double what the women's game was. Now, it's great to see the men's injury risk coming down, or their injury incidence coming down. And it may look scary that the women's injury incidence is increasing rapidly. But in terms of how this data is recorded, what we're probably really seeing here is an improvement in how well and how accurate the recording of injuries are. So as these come together, we're starting to see a more accurate profile of what the injuries look like. But at that, it still is fairly convincing that playing women's rugby as a whole is safer than the men's professional or international game at the minute. Concussion, conversely, if we look at the two graphs at the bottom, throughout the last 3 World Cup cycles have been very, very similar. And so, again, at first glance, and actually when you dive into it a bit closer, the injury incidence of concussion in women's sport is no higher than it is, or in women's rugby is no higher than it is in the men's game. What I would say, however, is that the proportion of concussions in the women's game is much higher than in the men's. So yes, you have the same number of concussions, or relatively speaking, the same number of concussions, but women overall have much less injuries, and so their proportion of injuries which are concussions are 27% versus in the men's game is 15%. And we don't quite know why this is at the minute, and it's something that's being looked into. But I would say that a lot of it is down to those things that we talked about previously. If we think about strength, it may be to do with neck strength. If we think about technique, it may be to do with running, tackling, change direction. And then if we think about all those provisions, it's about the coaching, the opportunities that we give girls, young girls, to play and to learn these skills from a very young age that will therefore decrease their risk going forward. One of the really interesting things that's out at the minute is a mouthguard study that looks at what they describe as head acceleration events. So they're not actually able to quantify the impact, but what they can do is quantify how quickly the head moves, and that seems to correlate very closely to a risk of concussion. And in the women's game, an area where it seems to be really stand out in comparison to the men's is that there's a much higher risk or much higher incidence of high head acceleration events in training as opposed to in the men's training, whereas the match incidences are fairly similar. So we don't know why this is. Again, it could be that the training the training is so compressed when international women's group get together that there is much more contact exposure, and as a result of that higher contact exposure, you're increasing your risk of concussion. Or it could be that conversely, the women are actually training at that level that we want them to be training at for match load, and that possibly even the men's game needs to come up. So we don't know the answer to that in the minute, but it is a really interesting area that's going to be explored further. I would be amiss not to talk about stress fractures when it comes to women's sport, because there definitely is an increased risk of stress fracture in women's sport in comparison to men. Now, the previous 2 injuries I discussed are what I would describe as traumatic injuries, whereas stress fracture is more of a load-related injury, and quite often it comes down to training error. So again, this is where provision of coaching, provision of education, and provision of services come in for female players, because if we can do all of these things, then we can reduce this stress fracture risk. The reason this comes up, there's something called the female athlete triad that has been around in sports medicine for a while, and we believe there was a belief that it was really only isolated to women's sport, and that belief was really down to the fact that it involved menstrual health and disturbance in menstrual function associated with high intensity exercise or prolonged high intensity exercise. But actually what we're seeing is this affects both women and men, and we've retermed it as a relative energy deficiency syndrome. And it really, what it is it describes a mismatch between how much training you're doing and how much you're fueling to I suppose, provide the energy for that training. And if there's a mismatch there, or a prolonged mismatch there, then what you do is you come into difficulties with both performance, but also things like health in general, both immune function, heart health, growth and development. But then specifically for us is this bone health. Your bones are alive, they're constantly turning over. And the risk is that when you're fuel depleted, or when you're not getting enough energy to supply your demands, then that turnover of bone health decreases. And so you start to develop what we describe as a bone stress injury, where the bone is not able to recover after the stresses that's being put through it. And ultimately you go on to develop a bone stress fracture. This is a slightly higher risk in women than it is in men, and we're not quite clear why that is. But it definitely is down to things like a perceived improved performance with a low body weight, And then if we take it back to then that idea of the advances in women's sport, the global eye on women's sport, there is a whole concern around body image in women's sport. And that does exist in men's as well, but it's definitely more prevalent in women's sport. And as a result, that idea of body image then brings around concerns with purposefully decreasing your intake. From a body image point of view, you end up with what we describe as disordered eating. And then unfortunately, that can sometimes progress onto something like an eating disorder. So this is something that we're very vigilant about. As I say, not just in the women's game, we're vigilant about it across the board, but at the minute, there does seem to be a higher risk associated with women. And so there is a huge educational piece in the importance of driving nutrition and fueling as a performance side of things, but also as an attempt to reduce injury risk. So I suppose in summary, there are a lot of things specific to the female athlete that increase their risk of injury, both traumatic injury and load-related injury. But for me, the main modifiable risk factors come right back down to that grassroots level, that growth and development of young girls and young females, and an education piece that we can encourage good practices right throughout the years of development, both from a nutrition point of view, from a scheduling, training practice point of view, the importance of strength, not just from a performance side of things, but also from an injury risk reduction side of things. And then the provision of services like footwear, good pitches, good equipment, good recovery tools, all of these things come together to reduce the risk of injury as a whole in women's sport. Thank you.
Thanks, Matt. Really great talk. First question from Nolene. Is there a greater risk of injury if a player has REDS? Is this something you consider or screen for?
So first off, yes, there definitely is an increased risk of injury. More so of a load-related injury, so soft tissue injury, something like a hamstring strain, calf strain, anything like that, as opposed to a traumatic injury. Traumatic injuries just happen sometimes, unfortunately. It's something we can't avoid. But I suppose in relation to traumatic injuries, the recovery time can be affected by REDS. So if you are energy deficient or energy depleted, then your recovery is going to be slower. So in that sense, there's a kind of an all-round downside to being affected by REDS. Can you screen for it? Yeah, very much so. There are a few different screening questionnaires that don't necessarily look for REDS specifically, but they look for different eating patterns and eating behaviors, and they may highlight low energy availability. And then there are a few other tests and investigations that sort of build a picture. There's no one single test that diagnoses REDS, but it's kind of a holistic picture, combination of history, examination, and then, as I say, there are a few questionnaires and some, for example, blood tests and scans that we can do that all contribute to the picture.
Okay, thanks. Is there any common injuries that occur in the Irish ladies team?
Yeah, so we have a slightly higher rate of knee injuries in general compared to other areas in the body. We track our injuries. We do an injury surveillance project every year to look at what are the common trends so that we can start to develop injury prevention programs and reduce risk of injury. Across the board, we find that knee injuries as a whole are slightly higher, and these tend to be traumatic injuries. We're quite fortunate in that we haven't had that many ACLs. MCL, medial collateral ligament injuries, are probably slightly higher for us. And we think that this is related to tackle technique, and probably some of the collision and close contact zone tackle drills and tackle play. We're trying to do a bit of a piece of research into this to try and look at it in a bit more detail and come up with a bit more clarity around why this is a problem and why it continues to be a theme for us.
Okay, thank you. Is there an increased risk of ACL re-rupture in women versus men?
Yeah, great question. There definitely is. there is not only an increased risk of re-rupture, the increased risk of re-rupture is about 4 times that of men, but there's also an increased risk of rupture to the other knee, so the unaffected knee, after an ACL injury, and that's about somewhere in the region of 6 to 8 times higher in women than in men. It's due to, I suppose, all the reasons why women are at slightly higher risk in the first instance. But then when you're thinking about rehabbing the ACL, you want to get the knee as strong as possible, the thigh, the hamstring. And if you're already coming from a baseline which is a little bit either weaker or has a slightly poor neuromuscular control, and even if you get it back to what you'd consider baseline, your baseline risk is always going to be there. So that's kind of the crux of why the risk is higher.
Okay, thanks. Someone asked a question here. Is surgery something you'd consider as a women rugby players who've had a grade 3 tear, I think that is in the ATFL and CFL? They have had steroid injections, but recurring sprains. Is there an alternative route? There's a couple of questions in there, actually.
So tricky one to answer just with the information that we have there. That's not really an exclusive question to women, female rugby players. I would take the same approach for a female rugby player as I would for a male soccer player or a female UAA player. And I suppose you would really need to have a good sense of what the problem is, what the symptoms and what the signs are. Grade 3, an ATFL and CFL injury are injuries to the lateral ankle ligament complex, and a grade 3 injury doesn't necessarily need surgery unless it's failed a period of kind of comprehensive rehabilitation. Typically, I wouldn't. This is where the question then comes in: what's the steroid injection being used for? We don't necessarily use the steroid injection to treat the tear. We sometimes use the steroid injection to treat some of the consequences of a ligament injury, to some of the consequences to the ankle joint itself. So it's difficult to give a black and white answer just with the information, but what I would say is that the mainstay treatment for any of the grade 3 ankle ligament injuries that I would treat would be a comprehensive rehab program. Sometimes I would use a steroid injection if the ankle joint itself is a bit stiff and sore and we're struggling to get through that rehab period. But if rehab has failed and it continues to be a problem and continues to get re-injured, then it's definitely something that I'd be considering.
Okay. Matt, thanks very much for joining us tonight. Just a reminder to everyone that these talks will be on the website. You will be able to access them, and we'll be sending out a feedback form and look for any suggestions of any talks you'd like to hear in the future. Our next event you can register for is on the 4th of October, which is about joint replacement. You can see there's a tab there if you want to download exercises or book an appointment with the hospital, with a surgeon, or you have any questions whatsoever. Thanks again for joining us tonight. We wish the Irish team the best of luck, and we'll see you at the next talk. Thank you.